Include good pasture syndrome, idiopathic pulmonary hemosiderosis, and vasculitis-associated hemorrhage. The latter encompasses conditions such as hypersensitivity angiitis, polyangiitis with granulomatosis, and systemic lupus erythematosus. Idiopathic pulmonary hemosiderosis. Idiopathic pulmonary hemosiderosis is a rare disorder characterized by intermittent diffuse alveolar hemorrhage. Most cases occur in young children, although the disease. Figure 15.31. Diffuse pulmonary hemorrhage syndrome. There is acute intraalveolar hemorrhage and hemosiderin-laden macrophages reflecting previous hemorrhage. Membrane antibodies has been reported in adults as well. It usually presents with an insidious onset of productive cough, hemoptysis, and anemia associated with diffuse pulmonary infiltrates. The cause and pathogenesis are unknown, and antibasement membrane antibodies the cause of good posture. Syndrome are undetectable. However, favorable response to long-term immunosuppression with prednisone, or, as azathioprine indicates, that an immunologic mechanism may be involved in the pulmonary capillary damage underlying alveolar bleeding. In addition, long-term follow-up shows that some affected patients develop other immune disorders. Good pasture syndrome, anti-glomerular basement, membrane antibody disease with pulmonary involvement. Good pasture syndrome is an uncommon autoimmune disease in which kidney and lung injury are caused by circulating autoantibodies against the non-collagenous domain of the 0,3 chain of collagen 4. When only renal disease is caused by this antibody, it is called anti-glomerular basement membrane disease. The term good pasture syndrome applies to the 40% to 60% of patients who develop pulmonary hemorrhage in addition to renal disease. Although any age can be affected, most cases occur in the teens or 22nd, and, in contrast to many other autoimmune diseases, there is a male preponderance. The majority of patients are active smokers. Pathogenesis. The immunopathogenesis of the syndrome and the nature of the good pasture antigens are described in Chapter 20. The pathogenic antibodies initiate inflammatory destruction of the basement membrane in renal glomeruli and pulmonary alveoli, giving rise to rapidly progressive glomerulonephritis and a necrotizing hemorrhagic interstitial pneumonitis, the trigger that initiates the production of antibasement. See Figure 15.30. Vascular changes in pulmonary membrane antibodies is unknown. In addition to autoreactive B cells, some experimental evidence suggests that T cells also contribute, both by enhancing B-cell function and by participating directly in glomerular damage and crescent formation. As with other autoimmune disorders, there is an association with certain HLA subtypes. Morphology. In the classic case, the lungs are heavy, with areas of red-brown consolidation. Histologically, there is focal necrosis of alveolar walls associated with intra-alveolar hemorrhages. Often, the alveoli contain hemosiderin-laden macrophages. In later stages, there may be fibrous thickening of the septa, hyperplasia of type 2 pneumocytes, and organization of blood in alveolar spaces. In many cases, immunofluorescence studies reveal linear deposits of immunoglobulins along the basement membranes of the septal walls. The kidneys have the characteristic findings of focal proliferative glomerulonephritis in early cases or crescentic glomerulonephritis in patients with rapidly progressive glomerulonephritis. Diagnostic linear deposits of immunoglobulins and complement are seen by immunofluorescence studies along the glomerular basement membranes, even in the few patients without renal disease. Clinical features: most cases begin with respiratory symptoms, principally hemoptysis, and radiographic evidence of focal pulmonary consolidations. Soon, manifestations of glomerulonephritis appear, leading to rapidly progressive renal failure. The most common cause of death is uremia. The once dismal prognosis for this disease has been markedly improved by intensive plasmapheresis. This procedure is thought to be beneficial by removing anti-basement membrane antibodies and possibly other mediators of immunologic injury. Simultaneous immunosuppressive therapy inhibits further antibody production, ameliorating both lung hemorrhage and glomerulonephritis. Polyangiitis with granulomatosis, previously called Wegener granulomatosis. This autoimmune disease most often involves the upper respiratory tract and/or the lungs, with hemoptysis being the common presenting symptom. Its features are discussed in Chapter 11. Here, it suffices to emphasize that a transbronchial lung biopsy might provide the only tissue available for diagnosis. Since the amount of tissue is small, necrosis and granulomatous vasculitis might not be present. Rather, the diagnostically important histologic features are capillaritis and scattered, poorly formed granulomas. Pulmonary infections. Respiratory tract infections are more frequent than infections of any other organ and account for the largest number of workdays lost in the general population. The vast majority consist of upper respiratory tract infections caused by viruses, but bacterial, viral, mycoplasmal, and fungal infections of the lung account for an enormous amount of morbidity and are responsible for 2.3% of all deaths in the United States. Pneumonia can be very broadly defined as any infection of the lung parenchyma. Pulmonary antimicrobial defense mechanisms are described in Chapter 8. Pneumonia can result whenever these local defense mechanisms are impaired or the systemic resistance of the host is lowered. Factors that impair resistance include chronic diseases, immunologic deficiencies, treatment with immunosuppressive agents, and leukopenia. Local pulmonary defense mechanisms may also be compromised by many factors, including loss or suppression of the cough reflex as a result of altered sensorium, anesthesia, neuromuscular disorders, drugs, or chest pain, any of which may lead to aspiration of gastric contents. Dysfunction of the mucociliary apparatus, which can be caused by cigarette smoke, inhalation of hot or corrosive gases, viral diseases, or genetic defects of ciliary function. Accumulation of secretions in conditions such as cystic fibrosis and bronchial obstruction. Interference with the phagocytic and bactericidal activities of alveolar macrophages by alcohol, tobacco smoke, anoxia, or oxygen intoxication. Pulmonary congestion and edema. Defects in innate immunity and humoral immunodeficiency typically lead to an increased incidence of infections with pyogenic bacteria. Germline mutations in MyD88 are also associated with destructive bacterial pneumonias. On the other hand, cell-mediated immune defects lead to increased infections with intracellular microbes, such as mycobacteria and herpes viruses, as well as with microorganisms of very low virulence, such as the fungus Pneumocystis jirovecii. Several other points should be emphasized. First, to paraphrase the French physician Louis Crouvellier in 1919, flu condemns and additional infection executes. The most common cause of death in viral influenza epidemics is superimposed bacterial pneumonia. Second, although the portal of entry for most bacterial pneumonias is the respiratory tract, hematogenous seeding of the lungs from another organ may occur and may be difficult to distinguish from primary pneumonia. Finally, many patients with chronic diseases acquire terminal pneumonia while hospitalized because of several factors. Bacteria common to the hospital environment may have acquired resistance to antibiotics, opportunities for spread are increased, invasive procedures such as intubations and injections are common, and bacteria may contaminate equipment used in respiratory care units. Pneumonia is classified based on the etiologic agent or, if no pathogen can be isolated, by the clinical setting in which the infection occurs. Table 15.7 Pneumonia syndromes. Community-acquired acute pneumonia. Streptococcus pneumoniae, Haemophilus. Influenzae moraxella, Catarrhalis. Staphylococcus, Aureus legionella pneumophila. Enterobacteriaceae and Pseudomonas, SPP. Mycoplasma pneumoniae chlamydia SPP. Coxiella burnetii viruses, respiratory syncytial virus, parainfluenza. The latter considerably narrows the list of suspected pathogens, providing a guide for empirical antimicrobial therapy. As Table 15.7 indicates, pneumonia can arise in 7 distinct clinical settings. and the implicated pathogens are fairly specific to each category. Community-acquired bacterial pneumonias. Community-acquired acute pneumonia refers to lung infection in otherwise healthy individuals that is acquired from the normal environment. It may be bacterial or viral. Clinical and radiologic features are usually insensitive in differentiating between viral and bacterial infections. One marker of inflammation, procalcitonin, an acute phase reactant produced, primarily in the liver, is more significantly elevated in bacterial than viral infections and has some predictive value, but is not specific, as it is also markedly elevated in other severe inflammatory disorders, such as systemic inflammatory response syndrome. Often, a bacterial infection follows an upper respiratory tract viral infection. Bacterial invasion of the lung parenchyma causes the alveoli to be filled with an inflammatory exudate, thus causing consolidation of the pulmonary tissue. Many variables, such as the specific etiologic agent, the host reaction, and the extent of involvement, determine the precise form of pneumonia. Predisposing conditions include extremes of age, chronic diseases, congenital or acquired immune deficiencies, and decreased or absent splenic function. The latter puts the patient at risk for infection with encapsulated bacteria such as pneumococcus, Streptococcus pneumoniae, or pneumococcus, is the most common cause of community-acquired acute pneumonia. Examination of gram-stained sputum is an important step in the diagnosis of acute pneumonia. The presence of numerous neutrophils containing the typical gram-positive lancet-shaped diplococci supports the diagnosis of pneumococcal pneumonia. But it must be remembered that S. pneumoniae is a part of the endogenous flora in 20% of adults, and therefore false positive results may be obtained. Isolation of pneumococci from blood cultures is more specific but less sensitive. Pneumococcal vaccines containing capsular polysaccharides from the common serotypes are used in individuals at high risk for pneumococcal sepsis. Haemophilus influenzae. Haemophilus influenzae is a pleomorphic gram-negative organism that occurs in encapsulated and non-encapsulated forms. There are 6 serotypes of the encapsulated form, of which type B is the most virulent. Antibodies against the capsule protect the host from H. influenzae infection, hence the capsular polysaccharide B is incorporated in the widely used vaccine against H. influenzae. With routine use of H. influenzae vaccines, the incidence of disease caused by the B serotype has declined significantly. By contrast, infections with non-encapsulated forms, also called non-typable forms, are increasing. These are less virulent and tend to spread along the surface of the upper respiratory tract, producing otitis media, sinusitis, and bronchopneumonia. Neonates and children with comorbidities such as prematurity, malignancy, and immunodeficiency are at high risk for development of invasive infection. H. influenzae pneumonia, which may follow a viral respiratory infection, is a pediatric emergency and has a high mortality rate. Descending laryngotracheobronchitis results in airway obstruction, as the smaller bronchi are plugged by dense, fibrin-rich exudates containing neutrophils, similar to that seen in pneumococcal pneumonias. Pulmonary consolidation is usually lobular and patchy, but may be confluent and involve the entire lung lobe. Before a vaccine became widely available, H. influenzae was a common cause of suppurative meningitis in children up to 5 years of age. H. influenzae also causes an acute purulent conjunctivitis in children and in predisposed older patients, may cause septicemia, endocarditis, pyelonephritis, cholecystitis, and suppurative arthritis. Finally, H. influenzae is the most common bacterial cause of acute exacerbations of COPD. Moraxella catarrhalis. Moraxella catarrhalis is recognized as a cause of bacterial pneumonia, especially in the elderly. It is the second most common bacterial cause of acute exacerbation of COPD. Along with S. pneumoniae and H. influenzae, M. catarrhalis is one of the 3 most common causes of otitis media in children. Staphylococcus aureus. Staphylococcus aureus is an important cause of secondary bacterial pneumonia in children and healthy adults following viral respiratory illnesses. Staphylococcal pneumonia is associated with a high incidence of complications, such as lung abscess and empyema. Intravenous drug users are at high risk for development of staphylococcal pneumonia in association with endocarditis. It is also an important cause of hospital-acquired pneumonia. Klebsiella pneumoniae. Klebsiella pneumoniae is the most frequent cause of gram-negative bacterial pneumonia. It commonly afflicts debilitated and malnourished people, particularly chronic alcoholics. Thick, mucoid sputum is characteristic because the organism produces an abundant viscid capsular polysaccharide, which the patient may have difficulty expectorating. Pseudomonas aeruginosa. Although Pseudomonas aeruginosa most commonly causes hospital-acquired infections, it is mentioned here because of its occurrence in cystic fibrosis and immunocompromised patients. It is common in patients who are neutropenic, and it has a propensity to invade blood vessels with consequent extrapulmonary spread. Pseudomonas septicemia is a very fulminant disease. Legionella pneumophila. Legionella pneumophila is the agent of Legionnaire's disease, the form of pneumonia caused by this organism. It also causes Pontiac fever, a related self-limited upper respiratory tract infection. This organism flourishes in artificial aquatic environments such as water cooling towers and the tubing systems of domestic water supplies. It is transmitted by either inhalation of aerosolized organisms or aspiration of contaminated drinking water. Legionella pneumonia is common in individuals with predisposing conditions such as cardiac, renal, immunologic, or hematologic disease. Organ transplant recipients are particularly susceptible. It can be quite severe, frequently requiring hospitalization, and immunosuppressed patients have fatality rates of up to 50%. The diagnosis can be made rapidly by detecting Legionella DNA in sputum using a polymerase chain reaction-based test or by identification of Legionella antigens in the urine. Culture remains the diagnostic gold standard, but takes 3 to 5 days. Bronchopneumonia, figure 15.32, comparison of bronchopneumonia and lobar pneumonia. Mycoplasma pneumoniae, mycoplasma infections are particularly common among children and young adults. They occur sporadically or as local epidemics in close communities. Morphology. Bacterial pneumonia has 2 patterns of anatomic distribution, lobular bronchopneumonia and lobar pneumonia. Patchy consolidation of the lung is the dominant characteristic of bronchopneumonia, while consolidation of a large portion of a lobe or of an entire lobe defines lobar. Figure 15.33, bronchopneumonia, section of lung showing patches of consolidation, lobar pneumonia. Granular, gray-red, A pneumonia. These anatomic categorizations may be difficult to apply in individual cases because patterns overlap. The patchy involvement may become confluent, producing lobar consolidation. Moreover, the same organisms may produce either pattern, depending on patient susceptibility. Most important from the clinical standpoint are identification of the causative agent and determination of the extent of disease. In lobar pneumonia, 4 stages of the inflammatory response have classically been described: congestion, red hepatization, gray hepatization, and resolution. In the first stage of congestion, the lung is heavy, boggy, and red. It is characterized by vascular engorgement, intra-alveolar edema fluid containing a few neutrophils, and the presence of bacteria, which may be numerous. In the next stage of red hepatization, there is massive confluent exudation, as neutrophils, red cells, and fibrin fill the alveolar spaces. On gross examination, the lobe is red, firm, and airless, with a liver-like consistency, hence the name hepatization. The third stage of gray hepatization is marked by progressive disintegration of red cells and the persistence of a fibrinosuppurative exudate, resulting in a color change to grayish-brown. In the final stage of resolution, the exudate within the alveolar spaces is broken down by enzymatic digestion to produce granular, semi-fluid debris that is resorbed, ingested by macrophages, expectorated, or organized by fibroblasts growing into it. Pleural fibrinous reaction to the underlying inflammation, often present in the early stages, if the consolidation extends to the lung surface, may similarly resolve. More often it undergoes organization, leaving fibrous thickening or permanent adhesions. Foci of bronchopneumonia are consolidated areas of acute suppurative inflammation. The consolidation may be confined to one lobe, but is more often multilobar and frequently bilateral and basal because of the tendency of secretions to gravitate to the lower lobes. Well-developed lesions are slightly elevated, dry. BC figure 15.35 stages of bacterial pneumonia. Pneumonia, granular, gray-red to yellow, and poorly delimited at their margins. Histologically, the reaction usually elicits a neutrophil-rich exudate that fills the bronchi, bronchioles, and adjacent alveolar spaces. Complications of pneumonia include tissue destruction and necrosis, causing abscess formation, spread of infection. Figure 15.34 lobar pneumonia, gray hepatization. The lower lobe is uniform. Figure 15.35 stages of bacterial pneumonia. Acute pneumonia. The congested septal capillaries and numerous intra-alveolar neutrophils are characteristic of early red hepatization. Fibrin nets have not yet formed. Early organization of intra-alveolar exudate, seen focally to be streaming through the pores of cone. Advanced organizing pneumonia. The exudates have been converted to fibromyxoid masses rich in macrophages and fibroblasts to the pleural cavity, causing an intrapleural fibrinosuppurative reaction known as empyema and bacteremic dissemination to the heart valves, pericardium, brain, kidney, spleen, or joints, causing abscesses, endocarditis, meningitis, or suppurative arthritis. Clinical features. The major symptoms of community-acquired acute bacterial pneumonia are abrupt onset of high fever, shaking, chills, and cough-producing mucopurulent sputum, and occasionally hemoptysis. When pleuritis is present, it is accompanied by pleuritic pain and pleural friction rub. The whole lobe is radiopaque in lobar pneumonia, whereas there are focal opacities in bronchopneumonia. The clinical picture is markedly modified by the administration of effective antibiotics. Appropriately treated patients may become afebrile, with few clinical signs 48 to 72 hours after the initiation of antibiotics. The identification of the organism and the determination of its antibiotic sensitivity are the keystones of therapy. Fewer than 10% of patients with pneumonia severe enough to merit hospitalization now succumb, and in most instances death results from a complication such as empyema, meningitis, endocarditis, or pericarditis, or is attributable to some predisposing influence, such as debility or chronic alcoholism. Community-acquired viral pneumonia. Common viral infections include influenza virus types A and B, respiratory syncytial viruses, human metapneumovirus, adenovirus, rhinoviruses, rubeola, and varicella viruses. Any of these agents can cause a relatively mild upper respiratory tract infection, recognized as the common cold, or a more severe lower respiratory tract infection. Factors that favor extension of the infection to the lung include extremes of age, malnutrition, alcoholism, and underlying debilitating illnesses. Although the molecular details vary, all of the viruses that cause pneumonia produce disease through similar general mechanisms. These viruses have tropisms that allow them to attach to and enter respiratory lining cells. Viral replication and gene expression leads to cytopathic changes, inducing cell death and secondary inflammation. The resulting damage and impairment of local pulmonary defenses, such as mucociliary clearance, may predispose to bacterial superinfections, which are often more serious than the viral infection itself. Influenza. Influenza viruses of type A infect humans, pigs, horses, and birds, and are the major cause of pandemic and epidemic influenza infections. The influenza genome encodes several proteins, but the most important from the vantage point of viral virulence are the hemagglutinin and neuraminidase proteins. Hemagglutinin has 3 major subtypes, while neuraminidase has 2. Both proteins are embedded in a lipid bilayer, which constitutes the influenza virus envelope. Hemagglutinin is particularly important, as it serves to attach the virus to its cellular target via sialic acid residues on surface polysaccharides. Following uptake of the virus into endosomal vesicles, acidification of the endosome triggers a conformation change in hemagglutinin that allows the viral envelope to fuse with the host cell membrane, releasing the viral genomic RNAs into the cytoplasm of the cell. Neuraminidase in turn facilitates the release of newly formed virions that are budding from infected cells by cleaving sialic acid residues. Neutralizing host antibodies against viral hemagglutinin and neuraminidase prevent and ameliorate, respectively, infection with influenza virus. The viral genome is composed of 8 single-stranded RNAs, each encoding one or more proteins. The RNAs are packaged into helices by nucleoproteins that determine the influenza virus type. A single subtype of influenza virus predominates throughout the world at a given time. Epidemics of influenza are caused by spontaneous mutations that alter antigenic epitopes on the viral hemagglutinin and neuraminidase proteins. These antigenic changes result in new viral strains that are sufficiently different to elude, at least in part, anti-influenza antibodies produced in members of the population in response to prior exposures to other flu strains. Usually, however, these new strains bear sufficient resemblance to prior strains that some members of the population are at least partially resistant to infection. By contrast, pandemics, which are longer and more widespread than epidemics, occur when both the hemagglutinin and the neuraminidase genes are replaced through recombination with animal influenza viruses. In this instance, essentially all individuals are susceptible to the new influenza virus. If the host lacks protective antibodies, the virus infects pneumocytes and elicits several cytopathic changes. Shortly after entry into pneumocytes, the viral infection inhibits sodium channels, producing electrolyte and water shifts that lead to fluid accumulation in the alveolar lumen. This is followed by the death of the infected cells through several mechanisms, including inhibition of host cell messenger RNA translation and activation of caspases leading to apoptosis. The death of epithelial cells exacerbates the fluid accumulation and releases danger signals that activate resident macrophages. In addition, prior to their death, infected epithelial cells release a variety of inflammatory mediators, including several chemokines and cytokines, adding fuel to the inflammatory fire. In addition, mediators released from epithelial cells and macrophages activate the nearby pulmonary endothelium and serve as chemoattractants for neutrophils, which migrate into the interstitium within the first day or two of infection. In some cases, viral infection may cause sufficient lung injury to produce ARTS, but more often severe pulmonary disease stems from a superimposed bacterial pneumonia. Of these, secondary pneumonias caused by S. aureus are particularly common and often life-threatening. Control of the infection relies on several host mechanisms. The presence of viral products induces innate immune responses in infected cells, such as the production of alpha and beta interferon. These mediators upregulate the expression of the MX1 gene, which encodes a guanosine triphosphatase that interferes with viral gene transcription and viral replication. As with other viral infections, natural killer cells and cytotoxic T cells can recognize and kill infected host cells, limiting viral replication and viral spread to adjacent pneumocytes. The cellular immune response is eventually augmented by development of antibody responses to the viral hemagglutinin and neuraminidase proteins. Insight into future pandemics has come from studying past pandemics. DNA analysis of viral genomes retrieved from the lungs of a soldier who died in the great 1918 influenza pandemic that killed between 20 million and 40 million people worldwide identified swine influenza sequences, consistent with this virus having its origin in an antigenic shift. The first flu pandemic of this century in 2009 was also caused by an antigenic shift involving a virus of swine origin. It caused particularly severe infections in young adults, apparently because older adults had antibodies against past influenza strains that conveyed at least partial protection. Comorbidities such as diabetes, heart disease, lung disease, and immunosuppression were also associated with a higher risk of severe infection. What then might be the source of the next great pandemic? There is no certainty, but one concern is centered on avian influenza, which normally infects birds. One such strain, type H5N1, has spread throughout the world in wild and domestic birds. Fortunately, the transmission of the current H5N1 avian virus is inefficient. However, if H5N1 influenza recombines with an influenza that is highly infectious for humans, a strain might result that is capable of sustained human-to-human transmission. Human metapneumovirus. Human metapneumovirus, a paramyxovirus, discovered in 2001, is found worldwide and is associated with upper and lower respiratory tract infections. Infections can occur in any age group, but are most common in young children, elderly adults, and immunocompromised patients. Some infections, such as bronchiolitis and pneumonia, are severe. Overall, metapneumovirus is responsible for 5% to 10% of hospitalizations and 12% to 20% of outpatient visits of children suffering from acute respiratory tract infections. Such infections are clinically indistinguishable from those caused by human respiratory syncytial virus and are often mistaken for influenza. The first human metapneumovirus infection occurs during early childhood, but reinfections are common throughout life, especially in older subjects. Diagnostic methods include PCR tests for viral RNA. Treatment generally focuses on supportive measures. Although work is ongoing, a clinically effective and safe vaccine has yet to be developed. Human coronaviruses. Coronaviruses are enveloped, positive-sense RNA viruses that infect humans and several other vertebrate species. Weakly pathogenic coronaviruses cause mild cold like upper respiratory tract infections, while highly pathogenic ones may cause severe, often fatal pneumonia. An example of a highly pathogenic type is SARS-CoV-2, a strain that emerged in late 2019 in China that is producing a still evolving pandemic as of early 2020. Highly pathogenic coronaviruses like SARS-CoV-2 bind the ACE2 protein on the surface of pulmonary alveolar epithelial cells, explaining the tropism of these viruses for the lung. With highly pathogenic forms in susceptible hosts, typically older individuals with comorbid conditions, the host immune response and locally released cytokines often produce acute lung injury and ARDS. Morphology. All viral infections produce similar morphologic changes. Upper respiratory infections are marked by mucosal hyperemia and swelling, infiltration of the submucosa by mononuclear cells, and overproduction of mucus secretions. The swollen mucosa and viscous exudate may plug the nasal channels, sinuses, or the eustachian tubes, leading to suppurative secondary bacterial infection. Virus-induced tonsillitis causing hyperplasia of the lymphoid tissue within the Waldeyer ring is frequent in children. In viral laryngotracheobronchitis and bronchiolitis there is vocal cord swelling and abundant mucus production. Impairment of bronchociliary function invites bacterial superinfection with more marked suppuration. Plugging of small airways may give rise to focal lung atelectasis. With more severe bronchiolar involvement, widespread plugging of secondary and terminal airways by cell debris, fibrin, and inflammatory exudate may, if prolonged, lead to organization and fibrosis, resulting in obliterative bronchiolitis and permanent lung damage. Lung involvement may be quite patchy, or may involve whole lobes bilaterally or unilaterally. The affected areas are red-blue and congested. Pleuritis or pleural effusions are infrequent. The histologic pattern depends on the severity of the disease. Predominant is an interstitial inflammatory reaction involving the walls of the alveoli. The alveolar septa are widened and edematous and usually contain a mononuclear inflammatory. Infiltrate of lymphocytes, macrophages, and occasionally plasma cells. In severe cases, neutrophils may also be present. The alveoli may be free of exudate, but in many patients there is intra-alveolar proteinaceous material and a cellular exudate. When complicated by ARDS, pink hyaline membranes line the alveolar walls. Eradication of the infection is followed by reconstitution of the normal lung architecture. Superimposed bacterial infection modifies this picture by causing ulcerative bronchitis, bronchiolitis, and bacterial pneumonia. Some viruses, such as herpes simplex, varicella, and adenovirus, may be associated with necrosis of bronchial and alveolar epithelium and acute inflammation. Characteristic viral cytopathic changes are described in Chapter 8. Clinical features. The clinical course of viral pneumonia is extremely varied. Many cases masquerade as severe upper respiratory tract infections or as chest colds. Even individuals with well-developed atypical pneumonia have few localizing symptoms. Cough may be absent, and the major manifestations may consist only of fever, headache, and myalgia. The edema and exudation often cause ventilation-perfusion mismatch, leading to hypoxemia, and thus evokes symptoms out of proportion to the scant physical findings. Viral pneumonias are usually mild and resolve spontaneously without any lasting sequelae. However, interstitial viral pneumonias may assume epidemic proportions, and in such instances, even a low rate of complications can lead to significant morbidity and mortality, as is typically true of influenza epidemics. Healthcare-associated pneumonia. Healthcare-associated pneumonia was recently described as a distinct clinical entity associated with several risk factors. These are hospitalization of at least 2 days within the recent past, presentation from a nursing home or long-term care facility, attending a hospital or hemodialysis clinic, and recent intravenous antibiotic therapy, chemotherapy, or wound care. The most common organisms isolated are methicillin-resistant S. aureus and P. aeruginosa. These patients have a higher mortality than those with community-acquired pneumonia, hospital-acquired pneumonia. Hospital-acquired pneumonias are defined as pulmonary infections acquired in the course of a hospital stay. They are common in patients with severe underlying disease, immunosuppression, prolonged antibiotic therapy, or invasive access devices such as intravascular catheters. Patients on mechanical ventilation are at particularly high risk. Superimposed on an underlying disease, hospital-acquired infections are serious and often life-threatening. Gram-positive Cotran and G-gram-negative Rodsare. The most common isolates. The same organisms predominate in ventilator-associated pneumonia, with gram-negative bacilli being somewhat more common in this setting. Key concepts. Acute pneumonia. S. pneumoniae is the most common cause of community-acquired acute pneumonia. The distribution of inflammation is usually lobar. Lobar pneumonias evolve through 4 stages: congestion, red, hepatization, gray hepatization, and resolution. Other common causes of acute bacterial pneumonias in the community include H. influenzae and M. catarrhalis, S. aureus, K. pneumoniae, P. aeruginosa, and L. pneumophila, seen particularly in individuals with comorbid conditions and in organ transplant recipients. Important causes of community-acquired viral pneumonia include influenza virus, metapneumonia virus, and coronavirus COVID-19. The latter, a newly emergent pathogen. Bacterial pneumonias are characterized by predominantly intra-alveolar neutrophilic inflammation, while viral pneumonia shows interstitial lymphocytic inflammation. Aspiration pneumonia. Aspiration pneumonia occurs in markedly debilitated patients or those who aspirate gastric contents, either while unconscious or during repeated vomiting. These patients have abnormal gag and swallowing reflexes that predispose to aspiration. The resultant pneumonia is partly chemical due to the irritating effects of gastric acid, and partly bacterial. Typically, more than one organism is recovered on culture, aerobes being more common than anaerobes. This type of pneumonia is often necrotizing, pursues a fulminant clinical course, and is a frequent cause of death. In patients who survive, lung abscess is a common complication. Microaspiration, in contrast, occurs frequently in almost all people, especially those with gastroesophageal reflux disease. It usually results in small, poorly formed, non-necrotizing granulomas with multinucleated foreign body giant cell reaction. It is usually inconsequential, but may exacerbate other pre-existing lung diseases such as asthma, interstitial fibrosis, and lung rejection. Lung abscess. The term pulmonary abscess describes a local suppurative process that produces necrosis of lung tissue. Oropharyngeal surgical or dental procedures, sinobronchial infections, and bronchiectasis play important roles in their development. Etiology and pathogenesis. Under appropriate circumstances, any bacterial pathogen can produce an abscess. Those that do so most commonly include aerobic and anaerobic streptococci, S. aureus, and a host of gram-negative organisms. Mixed infections often occur because of the important causal role played by inhalation of foreign material. Anaerobic organisms normally found in the oral cavity, including members of the bacteroids, Fusobacterium and Peptococcus genera, are the exclusive isolates in about 60% of cases. The causative organisms are introduced by the following mechanisms: aspiration of infective material. Risk factors include suppressed cough reflexes, severe dysphagia, protracted vomiting, and poor dental hygiene. Aspiration first causes pneumonia, which progresses to tissue necrosis and formation of lung abscess, antecedent primary lung infection. Post-pneumonic abscess formations are usually associated with S. aureus, K. pneumoniae, and pneumococcus. Post-transplant or otherwise immunosuppressed individuals are at special risk. Septic embolism. Infected emboli may arise from thrombophlebitis in any portion of the systemic venous circulation or from the vegetations of infective bacterial endocarditis on the right side of the heart and lodge in the lung. Neoplasia. Secondary infection is particularly common in bronchopulmonary segments obstructed by a primary or secondary malignancy. Miscellaneous. Traumatic penetrations of the lungs. Direct extension of suppurative infections from the esophagus, spine, subphrenic space, or pleural cavity, and hematogenous seeding of the lung by pyogenic organisms all may lead to lung abscess formation. When all these causes are excluded, there are still cases in which no discernible basis for the abscess formation can be identified. These are referred to as primary cryptogenic lung abscesses. Morphology. Abscesses vary in diameter from a few millimeters to large cavities, up to 6 centimeters. They may affect any part of the lung and may be single or multiple. Pulmonary abscesses due to aspiration are more common on the right because of the more vertical, right main bronchuses, and are most often single. Abscesses that. Figure 15.3. 6 cut surface of lung showing 2 abscesses. Develop in the course of pneumonia or bronchiectasis are usually multiple, basal, and diffusely scattered. Septic emboli and pyemic abscesses are multiple and may affect any region of the lungs. The cardinal histologic change in all abscesses is suppurative destruction of the lung parenchyma within the central area of cavitation. The abscess cavity may be filled with suppurative debris, or, if there is communication with an air passage, may be partially drained to create an air-containing cavity. Superimposed saprophytic infections are prone to develop within the necrotic debris. Continued infection leads to large, poorly demarcated, fetid, green-black, multilocular cavities designated gangrene of the lung. In chronic cases, considerable fibroblastic proliferation produces a fibrous wall. Clinical features. The manifestations of pulmonary abscesses are much like those of bronchiectasis and characteristically include cough, fever, and copious amounts of foul-smelling, purulent, or sanguineous sputum. Fever, chest pain, and weight loss are common. Clubbing of the fingers and toes may appear. The diagnosis can be only suspected from the clinical findings and must be confirmed radiologically. Whenever an abscess is discovered in older individuals, it is important to rule out an underlying carcinoma, which is present in 10% to 15% of cases. The course of abscesses is variable. With antimicrobial therapy, most resolve, leaving behind a scar. Complications include extension of the infection into the pleural cavity, hemorrhage, the development of brain abscesses or meningitis from septic emboli, and secondary amyloidosis. Chronic pneumonia. Chronic pneumonia is most often a localized lesion in the immunocompetent patient, with or without regional lymph node involvement. Typically, the inflammatory reaction is granulomatous and is caused by bacteria or fungi. Tuberculosis of the lung and other organs is described in Chapter 8. Chronic pneumonias caused by fungi are discussed here. Histoplasmosis H, capsulatum infection, is acquired by inhalation of dust particles from soil contaminated with bird or bat droppings that contain small spores, the infectious form of the fungus. It is endemic along the Ohio and Mississippi rivers and in the Caribbean. It is also found in Mexico, Central and South America, parts of Eastern and Southern Europe, Africa, Eastern Asia, and Australia. Like M. tuberculosis, H. capsulatum is an intracellular pathogen that is found mainly in phagocytes. The clinical presentations and morphologic lesions of histoplasmosis bear a striking resemblance to those of tuberculosis, including a self-limited and often latent primary pulmonary involvement, which may result in coin lesions on chest radiography, chronic progressive secondary lung disease, which is localized to the lung apices and causes cough, fever, and night sweats. Spread to extrapulmonary sites, including mediastinum, adrenal glands, liver, or meninges, and widely disseminated disease in immunocompromised patients. Histoplasmosis can occur in immunocompetent individuals, but as per usual is more severe in those with depressed cell-mediated immunity. The pathogenesis of histoplasmosis is incompletely understood. The portal of entry is virtually always the lung. Macrophages ingest, but cannot kill the organism without T-cell help, and this allows the organism to multiply within phagolysosomes and disseminate prior to the development of T-cell immunity, which takes 1 to 2 weeks in individuals with adequate cell-mediated immunity. The infection is controlled by Th helper T-cells that recognize fungal antigens and subsequently secrete IFN-gamma, which activates macrophages and enables them to kill intracellular yeasts. In addition, histoplasma induces macrophages to secrete TNF, which recruits and stimulates other macrophages to kill histoplasma. Morphology. In the lungs of otherwise healthy adults, histoplasma infections produce granulomas, which usually become necrotic and may coalesce to produce areas of consolidation. With spontaneous resolution or effective treatment, these lesions undergo fibrosis and concentric calcification. Histologic differentiation from tuberculosis, sarcoidosis, and coccidioidomycosis requires identification of the 3 to 5 thin-walled yeast forms, which may persist in tissues for years. In fulminant disseminated histoplasmosis, which occurs in immunosuppressed individuals, granulomas do not form. Instead, there are focal accumulations of mononuclear phagocytes filled with fungal yeasts throughout the body. The diagnosis of histoplasmosis may be established by serologic tests for antibodies and fungal antigens, culture, or identification of the fungus in tissue biopsies. The majority of cases resolve spontaneously. Progressive disease or disease in immunocompromised patients is treated with antifungal agents. Blastomycosis. Blastomyces dermatitidis is a soil-inhabiting dimorphic fungus. It causes disease in the central and southeastern United States. Infection also occurs in Canada, Mexico, the Middle East, Africa, and India. There are 3 clinical forms. Pulmonary. A B figure 15.37 histoplasmosis. Laminated histoplasma granuloma of the lung. Histoplasma capsulatum yeast forms fill phagocytes in the lung of a patient with disseminated histoplasmosis. Inset shows high-power detail of pear-shaped, thin-based budding yeasts. Blastomycosis, disseminated blastomycosis, and a rare primary cutaneous form that results from direct inoculation of organisms into the skin. The pneumonia most often resolves spontaneously, but it may persist or progress to a chronic lesion. Morphology. In the normal host, the lung lesions of blastomycosis are suppurative granulomas. Macrophages have a limited ability to ingest and kill B. dermatitidis, and the persistence of the yeast cells leads to the recruitment of neutrophils. In tissue, B. dermatitidis is a round 5 to 15 yeast cell that divides by broad-based budding. It has a thick, double-contoured cell wall and visible nuclei. Involvement of the skin and larynx is associated with marked epithelial hyperplasia, which may be mistaken for squamous cell carcinoma. Coccidioidomycosis. Almost everyone who inhales the spores of Coccidioides immitis becomes infected and develops a delayed type hypersensitivity reaction to the fungus, but most remain asymptomatic. Indeed, more than 80% of people in endemic areas of the southwestern and western United States and in Mexico have a positive skin test reaction. One reason for the infectivity of C. immitis is that infective arthroconidia, when ingested by alveolar macrophages, block fusion of the phagosome and lysosome, and so resist intracellular killing. Approximately 10% of infected people develop lung lesions, and less than 1% of people develop disseminated C. immitis infection, which frequently involves the skin and meninges. Certain ethnic groups and the immunosuppressed are at high risk for disseminated disease. Morphology. Within macrophages or giant cells, C. immitis is present as thick-walled, non-budding spherules 20 to 60 micrometers in diameter, often filled with small endospores. A pyogenic reaction is superimposed when the spherules rupture to release the endospores. Rare progressive C. immitis disease involves the lungs, meninges, skin, bones, adrenals, lymph nodes, spleen, or liver. At all these sites, the inflammatory response may be purely granulomatous, pyogenic, or mixed. A B figure 15.38 blastomycosis. Rounded budding yeasts larger than neutrophils are present. Note the characteristic thick wall and nuclei. Silver stain. Pulmonary disease in human immunodeficiency virus infection. Figure 15.3 are seen. Pneumonia in the immunocompromised host, the appearance of a pulmonary infiltrate, with or without signs of infection, is one of the most common and serious complications in patients whose immune defenses are suppressed by disease, immunosuppressive therapy for organ or hematopoietic stem cell transplants, chemotherapy for tumors, or irradiation. In addition to the usual pathogens, a wide variety of so-called opportunistic infectious agents, many of which rarely cause infection in normal hosts, can cause pneumonia, and often more than one agent is involved. Mortality from these opportunistic infections is high. Table 15.8 lists some of the opportunistic agents according to their prevalence and whether they cause local or diffuse pulmonary infiltrates. The differential diagnosis of such infiltrates includes drug reactions and involvement of the lung by tumor. The specific infections are discussed in Chapter 8. Of these, the ones that commonly involve the lung can be classified according to the etiologic agent, bacteria, viruses, and fungi. Pulmonary disease accounts for 30% to 40% of hospitalizations in HIV-infected individuals. Although the use of potent antiretroviral agents and effective chemoprophylaxis has markedly altered the incidence and outcome of pulmonary disease in HIV-infected persons, the plethora of infectious agents and other pulmonary lesions make diagnosis and treatment a distinct challenge. Some of the individual microbial agents afflicting HIV-infected individuals have already been discussed. This section focuses only on the general principles of HIV-associated pulmonary disease. Despite the emphasis on opportunistic infections, it must be remembered that bacterial lower respiratory tract infections caused by the usual pathogens are among the most serious pulmonary disorders in HIV infection. The implicated organisms include S. pneumoniae, S. aureus, H. influenzae, and gram-negative rods. Bacterial pneumonias in HIV-infected persons are more common, more severe, and more often associated with bacteremia than in those without HIV infection. Not all pulmonary infiltrates in HIV-infected individuals are infectious in etiology. A host of non-infectious diseases, including Kaposi sarcoma, non-Hodgkin lymphoma, and lung cancer, occur with increased frequency and must be excluded. The CD4 T cell count determines the risk of infection with specific organisms. As a rule of thumb, bacterial and tubercular infections are more likely at higher CD4 counts. Pneumocystis pneumonia usually strikes at CD4 counts less than 200 cells, while CMV, fungal, and mycobacterium, avium intracellular complex infections are uncommon until the disease is very advanced. Finally, pulmonary disease in HIV-infected persons may result from more than one cause, and even common pathogens may present with atypical manifestations. Therefore, the diagnostic workup of these patients may be more extensive than would be necessary in an immunocompetent individual. Lung transplantation. Table 15.8 Causes of pulmonary. Indications for transplantation may include almost all non-neoplastic terminal lung diseases, provided that the patient does not have any other serious disease that would preclude lifelong immunosuppressive therapy. The most common indications are end-stage COPD, idiopathic pulmonary fibrosis, cystic fibrosis, and idiopathic familial pulmonary arterial hypertension. Although bilateral lung transplantation offers better survival as compared to single lung, the latter may be performed to benefit two recipients from a single donor. When bilateral chronic infection is present, both lungs of the recipient must be replaced to remove the reservoir of infection. With improving surgical and organ preservation techniques, postoperative complications, e.g. anastomotic, dehiscence, vascular thrombosis, primary graft dysfunction are becoming rare. The transplanted lung is subject to two major complications: infection and rejection. Pulmonary infections in lung transplant patients are essentially those of any immunocompromised host discussed earlier. In the early post-transplant period, bacterial infections are most common, with ganciclovir prophylaxis and matching of donor-recipient CMV status. CMV pneumonia occurs less frequently and is less severe, although some resistant strains are emerging. Most infections occur in the 3rd to 12th month after transplantation. P. girovetzi pneumonia is rare, since almost all patients receive adequate prophylaxis, usually with trimethoprim sulfamethoxazole. Fungal infections are mostly due to Aspergillus and Candida species, and they may involve the bronchial anastomotic site and/or the lung. Acute lung allograft rejection occurs to some degree in all patients, despite routine immunosuppression. It most often appears several weeks to months after surgery, but also may present years later or whenever immunosuppression is decreased. Patients present with fever, dyspnea, cough, and radiologic infiltrates. Since these are similar to the picture of infections, diagnosis often relies on transbronchial biopsy. Chronic lung allograft rejection is a significant problem in at least half of all patients by 3 to 5 years post-transplant. It is manifested by cough, dyspnea, and an irreversible decrease in lung function due to pulmonary fibrosis. Morphology. The morphologic features of acute rejection are primarily those of inflammatory infiltrates around small vessels in the submucosa of airways, or both. The major morphologic correlate of chronic rejection is bronchiolitis obliterans, the partial or complete occlusion of small airways by fibrosis, with or without active inflammation. Bronchiolitis obliterans is patchy and therefore difficult to diagnose via transbronchial biopsy. Bronchiectasis and pulmonary fibrosis may also develop with long-standing chronic rejection. Acute cellular airway rejection is generally responsive to therapy, but the treatment of established bronchiolitis obliterans has been disappointing. Its progress may be slowed or even halted for some time, but it cannot be reversed. Infrequent complications of lung transplantation include Epstein-Barr virus, associated B-cell lymphoma, which most often arises within the lung allograft. With continuing improvement in surgical, immunosuppressive, and antimicrobial therapies, the outcome of lung transplantation has improved considerably. The overall median survival is 6 years, with younger patients and those undergoing bilateral lung transplantation having better outcomes. Figure 15.40 Chronic rejection of lung allograft associated with bronchial. An adjacent pulmonary artery is normal. Tumors of the wide variety of benign and malignant tumors that may arise in the lung, 90% to 95% are carcinomas, about 5% are carcinoid tumors, and 2% to 5% are mesenchymal and other miscellaneous neoplasms. Carcinomas. Lung cancer is currently the most frequently diagnosed major cancer and the most common cause of cancer mortality worldwide. Globally, in 2018, there were an estimated 2.1 million new cases and 1.8 million lung cancer deaths. The number of new cases of lung cancer in 2018 in the United States is expected to number approximately 230,000, accounting for about 14% of cancer diagnoses and taking more than 150,000 lives, which amounts to roughly 28% of all cancer-related deaths. Each year, lung cancer kills more people than colon, breast, and prostate cancer combined. It is generally a disease of older adults, occurring most often between ages 55 and 84 years, with a peak incidence between 65 and 74 years. Only 2% of all cases occur before the age of 40 because lung cancer is strongly linked to cigarette smoking. Changes in smoking habits greatly influence lung cancer incidence and mortality, as well as the prevalence of the various histologic types of lung cancer. Since the early 1990s, lung cancer incidence and mortality rates have been decreasing in men due to a decrease in male smoking over the past 35 years. However, the decrease in smoking among women has lagged behind that of men. Since 1987, more women have died each year of lung cancer than of breast cancer, which for more than 40 years had been the leading cause of cancer death in women. Etiology and pathogenesis. Most lung cancers are associated with a well-known carcinogen, cigarette smoke. In addition, there are other genetic and environmental factors. Lung cancers are broadly classified into small cell and non-small cell types, with the latter group including adenocarcinoma and squamous cell carcinoma. The driver mutations that cause lung cancer vary among these histologic subtypes, as will be described later. Tobacco smoking. About 80% of lung cancers occur in active smokers or those who stopped recently, and there is a nearly linear correlation between the frequency of lung cancer and pack years of cigarette smoking. The increased risk is 60 times greater in habitual heavy smokers than in non-smokers. However, since lung cancer develops in only 10% to 15% of smokers, there are likely to be other factors that interact with smoking to predispose individuals to this deadly disease. For unclear reasons, it appears that women are more susceptible to carcinogens in tobacco than men. Although cessation of smoking decreases the risk for lung cancer over time, it may never return to baseline levels. In fact, genetic changes that predate lung cancer can persist for many years in the bronchial epithelium of former smokers. Pipe and cigar smokers also incur an elevated risk, albeit only modestly. Chewing tobacco is not a safe substitute for smoking cigarettes or cigars, as these products spare the lung but cause oral cancers and can lead to nicotine addiction. The long-term effects of electronic cigarette aerosols are not known, as vaping is a relatively recent phenomenon. Unfortunately, the carcinogenic effects of tobacco smoke extend to those who live and work with smokers. Secondhand smoke, or environmental tobacco smoke, contains numerous human carcinogens for which there is no safe level of exposure. It is estimated that each year about 3,000 non-smoking adults die of lung cancer as a result of breathing secondhand smoke. What of heavy smokers who never develop cancer? While some of this may be a matter of chance, the mutagenic effect of carcinogens in smoke is modified by genetic variants. Recall that many chemicals are converted into carcinogens via activation by the highly polymorphic P450 monooxygenase enzyme system. Specific P450 variants have an increased capacity to activate procarcinogens in cigarette smoke, and smokers with these variants incur a greater risk of lung cancer. Similarly, individuals whose peripheral blood lymphocytes show more numerous chromosomal breakages after exposure to tobacco-related carcinogens have a greater than 10-fold higher risk of developing lung cancer as compared with controls, presumably because of genetic variation in genes involved in DNA repair. The histologic changes that correlate with steps along the path to neoplastic transformation are best documented for squamous cell carcinoma and are described in more detail later. There is a linear correlation between the intensity of exposure to cigarette smoke and the appearance of ever more worrisome epithelial changes. These begin with rather innocuous-appearing basal cell hyperplasia and squamous metaplasia and progress to squamous dysplasia and carcinoma in situ. the last stage before progression to invasive. Cancer. Industrial hazards. Certain industrial exposures, such as asbestos, arsenic, chromium, uranium, nickel, vinyl chloride, and mustard gas, increase the risk of developing lung cancer. High-dose ionizing radiation is carcinogenic. There was an increased incidence of lung cancer among survivors of the Hiroshima and Nagasaki atomic bomb blasts, as well as in workers heavily involved in cleanup after the Chernobyl disaster. Uranium is weakly radioactive, but lung cancer rates among non-smoking uranium miners are 4 times higher than those in the general population, and among smoking miners they are about 10 times higher. Asbestos exposure also increases the risk for lung cancer development. The latent period before the development of lung cancer is 10 to 30 years. Lung cancer is the most frequent malignancy in individuals exposed to asbestos, particularly when coupled with smoking. Asbestos workers who do not smoke have a 5-fold greater risk of developing lung cancer than do non-smoking control subjects, whereas those who smoke have a 55-fold greater risk. Air pollution. It is uncertain whether air pollution by itself increases the risk of lung cancer, but it likely adds to the risk in those who smoke or are exposed to secondhand smoke. It may do so through several different mechanisms. Chronic exposure to air particulates in smog may cause lung irritation, inflammation, and repair. And you will recall that chronic inflammation and repair increases the risk of a variety of cancers. A specific form of air pollution that may contribute to an increased risk of lung cancer is radon gas. Radon is a ubiquitous radioactive gas that has been linked epidemiologically to increased lung cancer in uranium miners. Other underground miners and workers in locations below ground, such as subways, tunnels, and basements, are at increased risk for radon exposure. This has generated concern that low-level exposure may also increase the incidence of lung cancer. Acquired mutations. As with other cancers, smoking-related carcinomas of the lung arise by a stepwise accumulation of oncogenic driver mutations that result in the neoplastic transformation of pulmonary epithelial cells. Some of the genetic changes associated with cancers can be found in the benign bronchial epithelium of smokers without lung cancers, suggesting that large areas of the respiratory mucosa are mutagenized by exposure to carcinogens in tobacco smoke. On this fertile soil, cells that accumulate just the wrong panoply of complementary driver mutations to acquire all of the hallmarks of cancer develop into carcinomas. The major histologic subtypes of lung cancer each have distinctive molecular features, as follows. Adenocarcinoma is associated with tobacco smoking, but less so than other histologic subtypes. As a result, it is the most common subtype in never smokers. About 1/3 of adenocarcinomas have oncogenic gain-of-function mutations involving components of growth factor receptor signaling pathways. These are important to recognize because they often can be targeted with specific inhibitors. These include gain-of-function mutations in genes encoding several different receptor tyrosine kinases, such as EGFR in 10% to 15% of tumors in Caucasians and a higher percentage of non-smoking Asian women, ALK, in 3% to 5% of tumors. ROS1 in 1% of tumors, MET in 2% to 5% of tumors, and RET in 1% to 2% of tumors. Other tumors have gain-of-function mutations in serine 3 kinases or in the KRAS gene, all of which encode signaling molecules that lie downstream of receptor tyrosine kinases in growth factor signaling pathways. Squamous cell carcinoma is highly associated with exposure to tobacco smoke and harbors diverse genetic aberrations, many of which are chromosome deletions involving tumor suppressor loci. These losses, especially those involving 3p, 9p, and 17p, are early events in tumor evolution, being detected at an appreciable frequency in the histologically normal respiratory mucosal cells of smokers. Most tumors have mutations in TP53, and P protein overexpression, a marker of TP53 mutations, is an early event, being reported in 10% to 50% of squamous dysplasias and 60% to 90% of squamous cell carcinoma in situ. The CDKN2A tumor suppressor gene, which encodes the cyclin-dependent kinase inhibitor P, is mutated in 65% of tumors. Many squamous cell carcinomas also have amplification of FGFR1, a gene encoding the fibroblast growth factor receptor tyrosine kinase. Small cell carcinoma is virtually always smoking-related and has the highest mutational burden among lung cancers. There is almost universal inactivation of both TP53 and RNB, and unusual transformations of non-small cell carcinoma to small cell carcinoma are often associated with acquisition of RNB loss-of-function mutations. Emphasizing the importance of RNB inactivation in this lung cancer subtype, loss of chromosome 3p also occurs in nearly all of these tumors, and is seen even in histologically normal lung epithelium, suggesting that this also is a critical early event. This subtype is also commonly associated with amplification of genes of the MyC family. Lung cancer in never smokers. The WHO estimates that 25% of lung cancer worldwide occurs in never smokers. This percentage is probably closer to 10% to 15% in Western countries. These cancers occur more commonly in women, and most are adenocarcinomas, often with targetable mutations, co-mutations. Cancers in non-smokers are more likely to have EGFR mutations and almost never have KRAS mutations. TP53 mutations are not uncommon, but occur less frequently than in smoking-related cancers. Precursor lesions. 4 types of morphologic precursor epithelial lesions are recognized. Atypical adenomatous hyperplasia, adenocarcinoma in situ, squamous dysplasia and carcinoma in situ, and diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It should be remembered that the term precursor does not imply that progression to cancer is inevitable. Currently, it is not possible to distinguish between precursor lesions that progress and those that remain localized or regress. Classification tumor. Classification is important for consistency in patient treatment and provides a uniform basis for epidemiologic and biologic studies. The most recent classification of lung. Table 15.9, histologic classification of malignant epithelial lung tumors. Tumor classification. Adenocarcinoma. Lipidic, acinar, micropapillary, papillary solid according to predominant. Pattern. Invasive mucinous adenocarcinoma, minimally invasive adenocarcinoma, squamous cell carcinoma, keratinizing, non-keratinizing, basaloid, neuroendocrine tumors. Small cell carcinoma, combined small cell carcinoma, large cell neuroendocrine carcinoma, combined large cell neuroendocrine carcinoma, carcinoid tumor. Typical, atypical. Other uncommon types. Large cell carcinoma adenosquamous, carcinoma sarcomatoid, carcinoma. Pleomorphic, spindle cell, giant cell carcinoma, carcinosarcoma. Pulmonary blastoma. Others, such as lymphepithelioma, like carcinoma, and nut carcinoma salivary gland type tumors. Cancer is given in Table 15.9. Several histologic variants of each type of lung cancer are described, however, their clinical significance is still undetermined except as mentioned herein. The relative proportions of the major categories are adenocarcinoma, squamous cell carcinoma, small cell carcinoma, large cell carcinoma, other. There may be mixtures of histologic patterns, even in the same cancer. Thus, combinations of squamous cell carcinoma and adenocarcinoma, or small cell and squamous cell carcinoma, occur in about 14% and 5% of patients, respectively. The incidence of adenocarcinoma has increased significantly in the last 2 decades, and it is now the most common form of lung cancer in women and men. The basis for this change is unclear. One possible factor is the increase in women smokers. But this only highlights our ignorance about why women develop adenocarcinoma more frequently. Another possibility is that changes in cigarettes may have caused smokers to inhale more deeply, increasing the exposure of peripheral airways and cells, with a predilection to give rise to adenocarcinoma to carcinogens. Morphology. Lung carcinomas may arise in the peripheral lung or in the central hilar region, sometimes in association with recognizable precursor lesions. Figure 15.4. 1 atypical adenomatous hyperplasia. The epithelium is cuboidal and there is mild interstitial fibrosis. Atypical adenomatous hyperplasia is a small precursor lesion characterized by dysplastic pneumocytes lining alveolar walls that are mildly fibrotic. It can be single or multiple and can be in the lung adjacent to invasive tumor or away from it. Adenocarcinoma in situ is a lesion that is less than 3 centimeters in size and is composed entirely of dysplastic cells growing along pre-existing alveolar septa. The cells have more dysplasia than atypical adenomatous hyperplasia and may or may not have intracellular mucin. Adenocarcinoma is an invasive malignant epithelial tumor with glandular differentiation or mucin production by the tumor cells. Adenocarcinomas grow in various patterns, including acinar, lipidic, papillary, micropapillary, and solid. Compared with squamous cell cancers, these lesions are usually more peripherally located and tend to be smaller. They vary histologically from Figure 15.42 adenocarcinoma in situ, mucinous subtype. Characteristic growth along pre-existing alveolar septa is evident without invasion. Well-differentiated tumors with obvious glandular elements, to papillary lesions resembling other papillary carcinomas, to solid masses with only occasional mucin-producing glands and cells. The majority express thyroid transcription factor 1, a protein first identified in the thyroid that is required for normal lung development. At the periphery of the tumor, there is often a lipidic pattern of spread, in which the tumor cells crawl along normal-appearing alveolar septa. Tumors with a small invasive component associated with scarring and a peripheral lipidic growth pattern are called microinvasive adenocarcinoma. These have a far better prognosis than invasive carcinomas of the same size. Mucinous adenocarcinomas tend to spread erogenously, forming satellite tumors. Thus, these are less likely to be cured by surgery. They may present as a solitary nodule, or as multiple nodules, or an entire lobe may be consolidated by tumor, mimicking lobar pneumonia. Squamous cell carcinoma is more common in men and is strongly associated with smoking. Precursor lesions that give rise to invasive squamous cell carcinoma are well characterized. Squamous cell carcinomas are often antedated by squamous metaplasia or dysplasia in the bronchial epithelium, which then transforms to carcinoma in situ, a phase that may last for years. By this time, atypical cells may be identified in cytologic smears of sputum or in bronchial lavage fluids or brushings, but the lesion is asymptomatic and undetectable on radiographs. Eventually, an invasive squamous cell carcinoma appears. The tumor may then follow a variety of paths. It may grow exophytically into the bronchial lumen, producing an intraluminal mass. With further enlargement, the bronchus becomes obstructed, leading to distal atelectasis and infection. The tumor may also penetrate the wall of the bronchus and infiltrate along the peribronchial tissue into the adjacent carina or mediastinum. In other instances, the tumor grows along a broad front to produce a cauliflower-like intraparenchymal mass that compresses the surrounding lung. As in almost all types of lung cancer, the neoplastic tissue is gray-white and firm to hard. Especially when the tumors are bulky, focal areas of hemorrhage or necrosis may appear to produce red or yellow-white mottling and softening. Sometimes these necrotic foci cavitate. Histologically, squamous cell carcinoma is characterized by the presence of keratinization and/or intercellular bridges. Keratinization may take the form of squamous pearls or individual cells with markedly eosinophilic cytoplasm. These features are prominent in well-differentiated tumors, are easily seen but not extensive in moderately differentiated tumors, and are focally seen in poorly differentiated tumors. Mitotic activity is higher in poorly differentiated tumors. In the past, most squamous cell carcinomas arose centrally from the segmental or subsegmental bronchi, but the incidence of squamous cell carcinoma of the peripheral lung is increasing. Squamous metaplasia, epithelial dysplasia, and foci of frank carcinoma in situ may be seen in bronchial epithelium adjacent to the tumor mass. Small cell carcinoma is a highly malignant tumor with a strong relationship to cigarette smoking. Only about 1% occurs in non-smokers. Tumors may arise in major bronchi or in the periphery of the lung. There is no known pre-invasive phase. They are the most aggressive of lung tumors, metastasizing widely and virtually always proving to be fatal. Small cell carcinoma is comprised of relatively small cells with scant cytoplasm, ill-defined cell borders, finely granular nuclei. A BCD figure 15.4, 3 histologic variants of lung carcinoma, gland-forming adenocarcinoma. Inset shows thyroid transcription factor 1 expression as detected by immunohistochemistry. Well-differentiated squamous cell carcinoma showing keratinization. Small cell carcinoma. There are islands of small, deeply basophilic cells and areas of necrosis. Large cell carcinoma. The tumor cells are pleomorphic and show no evidence of squamous or glandular differentiation. Chromatin and absent or inconspicuous nucleoli. The cells are round, oval or spindle-shaped, and nuclear molding is prominent. There is no absolute size for the tumor cells, but in general they are smaller than 3 times the diameter of a small resting lymphocyte. The mitotic count is high. The cells grow in clusters that exhibit neither glandular nor squamous organization. Necrosis is common and often extensive. Basophilic staining of vascular walls due to incrustation by DNA from necrotic tumor cells is frequently present. Combined small cell carcinoma is a variant in which typical small cell carcinoma is mixed with non-small cell histologies, such as large cell neuroendocrine carcinoma or even spindle cell morphologies resembling sarcoma. Electron microscopy shows dense core neurosecretory granules about 100 nanometers in diameter in 2/3 of cases of small cell carcinoma. The occurrence of neurosecretory granules, the expression of neuroendocrine markers such as chromogranin, synaptophysin, and CD56, and the ability of some of these tumors to secrete hormones suggests that this tumor originates from neuroendocrine progenitor cells, which are present in the lining bronchial epithelium. This simplistic idea is challenged, however, by the existence of tumors comprised of a mixture of small cell carcinoma and other histologies and well-documented transformations of non-small cell carcinoma to small cell carcinoma. Among the various types of lung cancer, small cell carcinoma is the one that is most commonly associated with ectopic hormone production. Large cell carcinoma is an undifferentiated malignant epithelial tumor that lacks the cytologic features of other forms of lung cancer. The cells typically have large nuclei, prominent nucleoli, and a moderate amount of cytoplasm. Large cell carcinoma is a diagnosis of exclusion, since it expresses none of the markers associated with adenocarcinoma or squamous cell carcinoma. One histologic variant is large cell neuroendocrine carcinoma, which has molecular features similar to those of small cell carcinoma, but is comprised of tumor cells of larger size. Combined carcinoma. Approximately 4% to 5% of all lung carcinomas have a combined histology, including 2 or more of the aforementioned types. Any type of lung carcinoma may extend to the pleural surface, and then spread within the pleural cavity or into the pericardium. Metastasis to the bronchial, tracheal, and mediastinal nodes can. A BF figure 15.4, 4 precursor lesions of squamous cell carcinomas. Some of the earliest changes in smoking-damaged respiratory epithelium include goblet cell hyperplasia, basal cell hyperplasia, and squamous metaplasia. More ominous changes include the appearance of squamous dysplasia, characterized by the presence of disordered squamous epithelium, with loss of nuclear polarity, nuclear hyperchromasia, pleomorphism, and mitotic figures. Squamous dysplasia may progress through the stages of mild, moderate, and severe dysplasia. Carcinoma in situ, the stage immediately preceding invasive squamous carcinoma, by definition has not penetrated the basement membrane and has cytologic features similar to those in frank carcinoma. Figure 15.45 Cytologic diagnosis of lung cancer. A sputum specimen shows an orange staining keratinized squamous carcinoma cell with a prominent hyperchromatic nucleus. Note the size of the tumor cells compared with normal neutrophils. Figure 15.46 lung carcinoma. The gray-white tumor infiltrates the lung parenchyma. Histologic sections identified this tumor as a squamous cell carcinoma, be found in most cases. The frequency of nodal involvement varies slightly with the histologic pattern, but averages greater than 50%. Distant spread of lung carcinoma occurs through both lymphatic and hematogenous pathways. These tumors often spread early throughout the body except for squamous cell carcinoma, which metastasizes late outside the thorax. Metastasis may be the first manifestation of an underlying occult pulmonary lesion. No organ or tissue is spared, but the adrenal glands, for obscure reasons, are involved in more than half of the cases. The liver, brain, and bone are other favored sites of metastases. Secondary pathology. Lung carcinomas have local effects that may cause several pathologic changes in the lung distal tube. The point of bronchial involvement, partial obstruction may cause marked focal emphysema. Total obstruction may lead to atelectasis. The impaired drainage of the airways is a common cause for severe suppurative or ulcerative bronchitis or bronchiectasis. Pulmonary abscesses sometimes call attention to an otherwise silent carcinoma. Compression or invasion of the superior vena cava can cause venous congestion and edema of the head and arm and ultimately circulatory compromise, the superior vena cava syndrome. Extension to the pericardial or pleural sacs may cause pericarditis or pleuritis with significant effusions. Apical lung cancers in the superior pulmonary sulcus tend to invade the neural structures around the trachea, including the cervical sympathetic plexus, and produce a group of clinical findings that include severe pain in the distribution of the ulnar nerve and Horner syndrome on the same side as the lesion. Such tumors are also referred to as Pancoast tumors. Staging. A uniform TNM system for staging cancer according to its anatomic extent at the time of diagnosis is useful, particularly for comparing treatment results from different centers. Clinical features lung cancer is one of the most insidious and aggressive neoplasms in the realm of oncology. In the usual case, it is discovered in patients in their 50s or older whose symptoms are of several months' duration. The major presenting complaints are cough, weight loss, chest pain, and dyspnea. Some of the more common local manifestations of lung cancer and their pathologic bases are listed in Table 15.1. Not infrequently, lung cancer is recognized through biopsy of tissues involved by metastatic disease. Symptoms of metastases depend on the site. For example, back pain in bone metastases and headache, hemiparesis, cranial nerve damage, and seizures in brain metastases. The best treatment for lung cancer is smoking prevention, which has lowered lung cancer incidence in the United States among men. However, 15% of adults still smoke, and even those who quit remain at elevated risk for an extended period of time. This reality has led to early detection trials in high-risk individuals using low-dose computed tomography, which is capable of detecting some early small cell lung cancers, but at a cost of a high incidence of false positive findings. Overall, the outlook is poor for most patients, even with incremental improvements. Table 15.10, International Staging System for Lung Cancer TNM Staging TIS Carcinoma in situ, Adenocarcinoma in situ. Adenocarcinoma with pure lipidic pattern, less than or equal to. Treatment of patients with adenocarcinoma and activating mutations in EGFR or in other tyrosine kinases with specific kinase inhibitors prolongs survival. Many tumors that recur carry new mutations that generate resistance to these inhibitors, proving that these drugs are hitting their target. In contrast, activating Cas mutations appear to be associated with a worse prognosis, regardless of treatment, in an already grim disease. Because of the mutagenic effects of carcinogens in tobacco smoke, lung cancers have a high burden of potentially antigenic neoantigens. Accordingly, both adenocarcinoma and squamous cell carcinoma respond in subsets of cases to checkpoint inhibitor therapy, which has produced improvements in survival and is now approved for use. Small cell carcinoma is quite sensitive to radiation therapy and chemotherapy, and approximately 10% of patients with limited disease survive for 5 years and may be cured. Unfortunately, however, most patients present with advanced stage disease. For these patients, despite excellent initial responses to chemotherapy, the median survival is approximately 10 months, and the cure rate is close to 0. New approaches involving use of antibody-drug conjugates that deliver chemotherapy selectively to tumor cells and immune checkpoint inhibitors are being tested. Paraneoplastic syndromes. Lung carcinoma can be associated with several paraneoplastic syndromes, some of which may antedate the development of a detectable pulmonary lesion. The hormones or hormone-like factors elaborated by lung cancer cells and associated syndromes include antidiuretic hormone, inducing hyponatremia due to inappropriate ADH secretion, adrenocorticotropic hormone, producing Cushing syndrome, parathormone, parathyroid hormone-related peptide, prostaglandin E, and some cytokines, all implicated in the hypercalcemia often seen with lung cancer. Calcitonin, causing hypocalcemia, gonadotropins, causing gynecomastia, serotonin and bradykinin associated with the carcinoid syndrome. The incidence of clinically significant paraneoplastic syndromes related to these factors in lung cancer patients ranges from 1% to 10%, although a much higher proportion of patients show elevated serum levels of these peptide hormones. Any histologic type of tumor may occasionally produce any one of the hormones, but tumors that produce ACTH and ADH are predominantly small cell carcinomas, whereas those that produce hypercalcemia are mostly squamous cell carcinomas. Other systemic manifestations of lung carcinoma include the Lambert-Eaton myasthenic syndrome, in which muscle weakness is caused by autoantibodies possibly elicited by tumor ionic channels directed to the neuronal calcium channel, peripheral neuropathy, usually purely sensory, dermatologic abnormalities, including acanthosis nigricans, hematologic abnormalities, such as leukemoid reactions, hypercoagulable states, such as Trousseau syndrome, and finally, a peculiar abnormality of connective tissue called hypertrophic pulmonary osteoarthropathy, associated with clubbing of the fingers. Key concepts: carcinomas of the lung. The three major histologic subtypes are adenocarcinoma, most common, squamous cell carcinoma, and small cell carcinoma. Each of these is clinically and genetically distinct. Small cell lung carcinomas are best treated by chemotherapy because almost all are metastatic at presentation. The other carcinomas may be curable by surgery if limited to the lung. Combination. Chemotherapy also is available along with tyrosine kinase inhibitors for those with EGFR, ALK, ROS, and MET mutations. Smoking is the most important risk factor for lung cancer. The most common subtype related to smoking in men and women is adenocarcinoma. Adenocarcinoma also is the most common subtype in non-smokers. Precursor lesions include atypical adenomatous hyperplasia and adenocarcinoma in situ for adenocarcinomas and squamous dysplasia for squamous cell carcinoma. Tumors 3 centimeters or less in diameter, characterized by pure growth along pre-existing structures without stroma. Invasion are now called adenocarcinoma in situ. Lung cancers, particularly small cell lung carcinomas, often cause paraneoplastic syndromes, neuroendocrine proliferations, and tumors. The normal lung contains neuroendocrine cells within the epithelium as single cells or as clusters, the neuroepithelial bodies. Virtually all pulmonary neuroendocrine cell hyperplasias are secondary to airway fibrosis and or inflammation. The exception is a rare disorder called diffuse idiopathic Pulmonary neuroendocrine cell hyperplasia, in which hyperplasia occurs in the absence of an inflammatory stimulus. Neoplasms of neuroendocrine cells in the lung include benign tumorlets, small, inconsequential, hyperplastic nests of neuroendocrine cells seen in areas of scarring or chronic inflammation, carcinoids, and the highly aggressive small cell carcinoma and large cell neuroendocrine carcinoma of the lung. Carcinoid tumors are classified separately, since they differ significantly from carcinomas, with evidence of neuroendocrine differentiation in terms of incidence and clinical, epidemiologic, histologic, and molecular characteristics. For example, in contrast to small cell and large cell neuroendocrine carcinomas, carcinoids may occur in patients with multiple endocrine neoplasia type 1. Carcinoid tumors. Carcinoid tumors represent 1% to 5% of all lung tumors. Most patients with these tumors are younger than 60 years of age, and the incidence is equal for both sexes. Approximately 20% to 40% of patients are non-smokers. Carcinoid tumors are low-grade malignant epithelial neoplasms that are subclassified into typical and atypical carcinoids. Morphology. Carcinoids may arise centrally or may be peripheral. On gross examination, the central tumors grow as finger-like or spherical polypoid masses that commonly project into the lumen of the bronchus and are usually covered by an intact mucosa. They rarely exceed 3 to 4 centimeters in diameter. Most are confined to the main stem bronchi. Others, however, penetrate the bronchial wall to fan out in the peribronchial tissue, producing the so-called collar button lesion. Peripheral tumors are solid and nodular. Histologically, the tumor is composed of organoid, trabecular, palisading, ribbon, or rosette-like arrangements of cells separated by a delicate fibrovascular stroma. In common with the lesions of the gastrointestinal tract, the individual cells are quite regular and have uniform round nuclei and a moderate amount of eosinophilic cytoplasm. Typical carcinoids have fewer than 2 mitoses per 10 high power fields and lack necrosis, while atypical carcinoids have between 2 and 10 mitoses per 10 high power fields and/or foci of necrosis. Atypical carcinoids also show increased pleomorphism, have more prominent nucleoli, and are more likely to grow in a disorganized fashion and invade lymphatics. On electron microscopy, the cells exhibit the dense core granules characteristic of other neuroendocrine tumors, and by immunohistochemistry are found to contain serotonin, neuron-specific enolase, bombesin, calcitonin, or other peptides. Clinical features. The clinical manifestations of bronchial carcinoids emanate from their intraluminal growth, their capacity to metastasize, and the ability of some of the lesions to elaborate vasoactive amines. Persistent cough, hemoptysis, impairment of drainage of respiratory passages with secondary infections, bronchiectasis, emphysema, and atelectasis are all byproducts of the intraluminal growth of these lesions. Most interesting are functioning lesions capable of producing the classic carcinoid syndrome, characterized by intermittent attacks of diarrhea, flushing, and cyanosis. Approximately 10% of bronchial carcinoids give rise to this syndrome. Overall, most bronchial carcinoids do not have secretory activity and do not metastasize to distant sites, but follow a relatively benign course for long periods and are therefore amenable to resection. The reported 5-year survival rates are 95% for typical carcinoids, 70% for atypical carcinoids, 30% for large cell neuroendocrine carcinoma, and 5% for small cell carcinoma, respectively. Miscellaneous tumors. Benign and malignant mesenchymal tumors, such as inflammatory myofibroblastic tumor, fibroma, fibrosarcoma, lymphangioleiomyomatosis, leiomyoma, leiomyosarcoma, lipoma, hemangioma, and chondroma, may occur in the lung but are rare. Hematolymphoid tumors, similar to those described in other organs, may also affect the lung, either as isolated lesions or, more commonly, as part of a generalized disorder. These include Langerhans cell histiocytosis, a B, figure 15.4, 7 bronchial carcinoid. Carcinoid growing as a spherical mass protruding into the lumen of the bronchus. The tumor cells have small, rounded, uniform nuclei and moderate amounts of cytoplasm. Hodgkin lymphomas, lymphomatoid granulomatosis, an unusual EBV-positive B-cell lymphoma, and low-grade extranodal marginal zone B cell lymphoma. Pulmonary hamartoma is a relatively common lesion that is usually discovered as an incidental, rounded radiopacity on a routine chest film. Most are solitary, less than 3 to 4 centimeters in diameter, and well circumscribed. Pulmonary hamartoma consists of nodules of connective tissue intersected by epithelial clefts. Cartilage is the most common connective tissue, but there may also be fibrous tissue and fat. The clefts are lined by ciliated or non-ciliated epithelium. The traditional term hamartoma is retained for this lesion, but it is in fact a clonal neoplasm associated with chromosomal aberrations involving either 6p or 12q. These aberrations are found in the mesenchymal component, while the epithelial component appears to represent entrapped respiratory epithelium. Lymphangioliomyomatosis is a pulmonary disorder that primarily affects young women of childbearing age. It is characterized by a proliferation of perivascular epithelioid cells that express markers of both melanocytes and smooth muscle cells. The proliferation distorts the involved lung, leading to cystic, emphysema-like dilation of terminal air spaces, thickening of the interstitium, and obstruction of lymphatic vessels. The lesional epithelioid cells frequently harbor loss-of-function mutations in the tumor suppressor TSC2, one of the loci linked to tuberous sclerosis. The protein encoded by TSC2, tuberin, is a negative regulator of mammalian target of rapamycin, a key regulator of cellular metabolism. While TSC2 mutations point to increased mTOR activity as a pathogenic factor, the disorder remains poorly understood. The strong tendency to affect young women suggests that estrogen contributes to the proliferation of perivascular epithelioid cells, which often express estrogen receptors. Patients most commonly present with dyspnea or spontaneous pneumothorax, the latter related to emphysematous changes. The disease tends to be slowly progressive over a period of several decades. mTOR inhibitors slow or prevent the deterioration of lung function, but must be continued indefinitely. Only lung transplantation is curative. Table 15.1. 2 mediastinal neoplasms and inflammatory myofibroblastic tumor is a rare tumor that is more common in children with an equal male-to-female ratio. Presenting symptoms include fever, cough, chest pain, and hemoptysis. It may also be asymptomatic. Imaging studies usually show a round, well-defined peripheral mass. Calcification is present in about a quarter of cases. Grossly, the lesion is firm, 3 to 10 centimeters in diameter, and grayish-white. Microscopically, there is proliferation of spindle-shaped fibroblasts and myofibroblasts, lymphocytes, plasma cells, and peripheral fibrosis. Some of these tumors have activating rearrangements of the ALK receptor tyrosine kinase gene located on 2p, and treatment with ALK inhibitors have produced sustained responses in such cases. Tumors in the mediastinum may arise in mediastinal structures or may be metastatic from the lung or other organs. They often invade or compress the lungs. Table 15.1. 2 lists the most common tumors in the various compartments of the mediastinum. Specific tumor types are discussed in appropriate sections of this book. Metastatic tumors. The lung is the most common site of metastatic neoplasms. Both carcinomas and sarcomas arising anywhere in the body may spread to the lungs via the blood or lymphatics or by direct continuity. Esophageal carcinoma and mediastinal lymphoma may also invade the lung by direct extension. Morphology. The pattern of metastatic spread to the lungs is quite variable. In the usual case, multiple discrete nodules are scattered throughout all lobes, particularly in the lung periphery. Other times spread takes the form of a solitary nodule, endobronchial or pleural involvement, pneumonic consolidation, and/or some combination thereof. Foci of lipidic growth, similar to adenocarcinoma in situ, are seen occasionally with metastatic carcinomas and may be associated with any of the listed patterns. Figure 15.48. Pulmonary hamartoma. There are islands of cartilage, fat, smooth muscle, and entrapped respiratory epithelium. Figure 15.49. Numerous metastases to lung from a renal cell carcinoma. Pleura. Most pleural disorders stem from complications of disease arising elsewhere in the body. Secondary infections and inflammations are particularly common findings at autopsy. Important primary disorders include intrapleural bacterial infections, presumably the product of seeding from transient bacteremia, and mesothelioma, a primary pleural neoplasm. Pleural effusion. Pleural effusion is a common manifestation of both primary and secondary pleural diseases, which may be inflammatory or non-inflammatory. Normally, no more than 15 ml of serous, relatively acellular clear fluid lubricates the pleural surface. Accumulation of pleural fluid occurs in the following settings: increased hydrostatic pressure, as in congestive heart failure; increased vascular permeability, as in pneumonia; decreased osmotic pressure, as in nephrotic syndrome; increased intrapleural negative pressure, as in atelectasis; decreased lymphatic drainage, as in mediastinal carcinomatosis. Inflammatory pleural effusions, serous, serofibrinous, and fibrinous pleuritis all have an inflammatory basis, differing only in the intensity and duration of the process. The most common causes of pleuritis are disorders associated with inflammation of the underlying lung, such as tuberculosis, pneumonia, lung infarction, lung abscess, and bronchiectasis. Rheumatoid arthritis, systemic lupus erythematosus, uremia, diffuse systemic infections, and metastatic involvement of the pleura can also cause serous or serofibrinous pleuritis. Radiotherapy for tumors in the lung or mediastinum often causes a serofibrinous pleuritis. In most of these disorders, the pleural reaction is minimal, and the fluid exudate is resolved with either resolution or organization of the fibrinous component. However, large amounts of fluid sometimes accumulate and compress the lung, causing respiratory distress. A purulent pleural exudate usually results from bacterial or mycotic seeding of the pleural space. Most commonly, this seeding occurs by contiguous spread of organisms from intrapulmonary infection, but occasionally it occurs through lymphatic or hematogenous dissemination from a more distant source. Rarely, infections below the diaphragm, such as the subdiaphragmatic or liver abscess, may extend by continuity through the diaphragm into the pleural spaces, more often on the right side. Empyema is characterized by loculated yellow-green creamy pus composed of masses of neutrophils admixed with other leukocytes. Although empyema may accumulate in large volumes, usually the volume is small, and the pus becomes walled off by fibrosis. Empyema may resolve, but more often the exudate organizes into dense, tough fibrous adhesions that frequently obliterate the pleural space or envelop the lungs. Either can seriously restrict pulmonary expansion. Hemorrhagic pleuritis, manifested by sanguineous inflammatory exudates, is infrequent and is most often associated with hemorrhagic diatheses, rickettsial infections, and neoplastic involvement of the pleural cavity. The sanguineous exudate must be differentiated from hemothorax. When hemorrhagic pleuritis is encountered, a careful search should be made for the presence of tumor cells. Non-inflammatory pleural effusions. Non-inflammatory collections of serous fluid within the pleural cavities are called hydrothorax. The fluid is clear and straw-colored. Hydrothorax may be unilateral or bilateral, depending on the underlying cause. The most common cause of hydrothorax is heart failure, and for this reason it is usually accompanied by pulmonary congestion and edema. Hydrothorax may also be seen in any other systemic disease associated with generalized edema, such as patients with renal failure or cirrhosis of the liver. The escape of blood into the pleural cavity is known as hemothorax. It is most commonly a complication of trauma or less commonly surgery, but can also accompany rupture of an aortic aneurysm, a setting in which it is almost invariably fatal. Chylothorax is an accumulation of milky fluid, usually of lymphatic origin, in the pleural cavity. Chyle is milky white because it contains finely emulsified fats. Chylothorax is most often caused by thoracic duct trauma or by obstruction of a major lymphatic duct, usually by a malignancy. Such cancers most commonly arise within the thoracic cavity and invade the lymphatics locally, but occasionally more distant cancers metastasize via the lymphatics and grow within the right lymphatic or thoracic duct, producing obstruction. Pneumothorax. Pneumothorax refers to air or gas in the pleural cavities and is most commonly associated with emphysema, asthma, and tuberculosis. It may be spontaneous, traumatic, or therapeutic. Spontaneous pneumothorax may complicate any form of pulmonary disease that causes emphysematous changes. An abscess cavity that communicates either directly with the pleural space or with the lung interstitial tissue may also lead to the escape of air. In the latter circumstance, the air may dissect through the lung substance or back through the mediastinum, eventually entering the pleural cavity. Traumatic pneumothorax is usually caused by some perforating injury to the chest wall, but sometimes the trauma pierces the lung and thus provides two avenues for the accumulation of air within the pleural spaces. Resorption of the air in the pleural space occurs in spontaneous and traumatic pneumothorax, provided that the original communication seals itself. Of the various forms of pneumothorax, the one that attracts the most clinical attention is spontaneous idiopathic pneumothorax. This entity is encountered in relatively young people, seems to be due to rupture of small peripheral, usually apical subpleural blebs, and usually subsides spontaneously as the air is resorbed. Recurrent attacks are common and can be quite disabling. Pneumothorax may cause marked respiratory distress due to collapse and atelectasis of the lung. In some instances, the pleural defect acts as a flap valve and permits the entrance of air during inspiration but fails to permit its escape during expiration. The result is called attention pneumothorax, in which progressively increasing intrapleural pressure may compress vital mediastinal structures and the contralateral lung. Pleural tumors. The pleura may be involved by primary or secondary tumors. Secondary metastatic involvement is far more common than our primary tumors. The most frequent metastatic malignancies arise from primary neoplasms of the lung and breast. In addition to these cancers, malignancy from any organ of the body may spread to the pleural spaces. Ovarian carcinomas, for example, tend to cause widespread implants in both the abdominal and thoracic cavities. Most metastatic implants produce a serous or serosanguinous effusion that often contains neoplastic cells. For this reason, careful cytologic examination of the sediment is of considerable diagnostic value. Solitary fibrous tumor. Solitary fibrous tumor is a soft tissue tumor with a propensity to occur in the pleura and, less commonly, in the lung, as well as other sites. The tumor is often attached to the pleural surface by a pedicle. It may be small or may reach an enormous size, but it tends to remain confined to the surface of the lung. Morphology grossly, solitary fibrous tumor consists of dense fibrous tissue with occasional cysts filled with viscid fluid. Microscopically, the tumor shows whorls of reticulin and collagen fibers, among which Figure 15.50 solitary fibrous tumor. Cut surface is solid with a whorled appearance, are interspersed spindle cells resembling fibroblasts. Rarely this tumor may be malignant, marked by pleomorphism, mitotic activity, necrosis, and large size. The tumor cells are positive for CD34 and STAT6 and negative for keratin by immunostaining, features that help to distinguish this lesion from malignant mesothelioma. The solitary fibrous tumor has no relationship to asbestos exposure. Solitary fibrous tumor is highly associated with a cryptic inversion of chromosome 12 involving the genes NAB2 and STAT6. This rearrangement creates a NAB2 STAT6 fusion gene that appears to be virtually unique to solitary fibrous tumor. It encodes a chimeric transcription factor that is hypothesized to be a key driver of tumor development. Malignant mesothelioma. Malignant mesothelioma, although rare, has assumed great importance in the past few decades because of its increased incidence among people with heavy exposure to asbestos. Thoracic mesothelioma arises from either the visceral or the parietal pleura. In coastal areas with shipping industries in the United States and Great Britain, as well as in Canadian, Australian, and South African mining areas, as many as 90% of mesotheliomas are asbestos-related. The lifetime risk of developing mesothelioma in heavily exposed individuals is as high as 7% to 10%. There is a long latent period of 25 to 45 years for the development of asbestos-related mesothelioma, and there seems to be no increased risk of mesothelioma in asbestos workers who smoke. This is in contrast to the risk of asbestos-related lung carcinoma, which is markedly magnified by smoking. Thus, asbestos workers are at much higher risk of dying of lung carcinoma than mesothelioma. Asbestos bodies are found in increased numbers in the lungs of patients with mesothelioma. Another marker of asbestos exposure, the asbestos plaque, has been previously discussed. Although several cytogenetic abnormalities have been detected, the most common is homozygous deletion of chromosome 9p, leading to loss of the tumor suppressor gene CDKN2A, which occurs in about 80% of mesotheliomas. Sequencing of mesothelioma genomes has shown that driver mutations are also common in the NF2 gene, which encodes a cell signaling regulator, and BAP1, which encodes a protein that interacts with the BRCA1 tumor suppressor and appears to function as a chromatin regulator. Of note, individuals with germline mutations in BAP1 have a markedly elevated risk of mesothelioma, further implicating this tumor suppressor gene in the pathogenesis of the disease. A. Morphology. Malignant mesothelioma is a diffuse lesion arising from either the visceral or the parietal pleura that spreads widely in the pleural space and is usually associated with extensive pleural effusion and direct invasion of thoracic structures. The affected lung becomes ensheathed by a thick layer of soft, gelatinous, grayish-pink tumor tissue. Microscopically, malignant mesothelioma may be epithelioid, sarcomatoid, or biphasic, 10% too. This is in keeping with the fact that mesothelial cells have the potential to develop as epithelium-like cells or mesenchymal stromal cells. The epithelioid type of mesothelioma consists of cuboidal, columnar, or flattened cells forming tubular or papillary structures, resembling adenocarcinoma. Immunohistochemical stains are very helpful in differentiating it from pulmonary adenocarcinoma. Most mesotheliomas show strong positivity for keratin proteins, carotinin, Wilms tumor 1, cytokeratin 5, 6, and portoplanin. And unlike adenocarcinomas are negative for claudine. This panel of antibodies is diagnostic in a majority of cases when interpreted in the context of morphology and clinical presentation. The mesenchymal type of mesothelioma has an appearance resembling fibrosarcoma. B. Figure 15.5. Two histologic sarcomatoid mesotheliomas tend to have lower expression of many of the markers described previously, and some may be positive only for keratin. The biphasic type of mesothelioma contains both epithelioid and sarcomatoid patterns. Figure 15.5. One malignant mesothelioma. Note the thick, firm, white pleural tumor tissue that ensheathes the lung. Clinical features: the presenting symptoms are chest pain, dyspnea, and, as noted, recurrent pleural effusions. Concurrent pulmonary asbestosis is present in only 20% of individuals with pleural mesothelioma. The lung is invaded directly, and there is often metastatic spread to the hilar lymph nodes and eventually to the liver and other distant organs. 50% of patients die within 12 months of diagnosis, and few survive longer than 2 years. Aggressive therapy seems to improve this poor prognosis in some patients. Mesotheliomas also arise in the peritoneum, pericardium, tunica vaginalis, and genital tract. Peritoneal mesotheliomas are related to heavy asbestos exposure in 60% of male patients, although in about half of cases, the disease remains confined to the abdominal cavity. Intestinal involvement frequently leads to death from intestinal obstruction or inanition. Suggested readings: Barnes, P.J.